Mabuhay. I am Teddy. Welcome to Tiva TCI Track. The current role of Tiva TCI in infants and children has been limited by available pumps with no module for younger infants, pharmacokinetics, and neuromonitoring. This afternoon, we are privileged to have three experienced speakers who will share challenging cases using Tiva TCI technique. An infant for neurosurgery requiring neuromonitoring, an infant coming for endoscopic airway assessment, and a child with special needs coming for ambulatory surgery. Joining me this afternoon as my co-moderator is Dr. Usha Nair from Ipoh, Malaysia. How are you, Dr. Usha?
I'm good, Teddy. Good afternoon. Happy to be here.
All right. Okay. Great to hear that you are doing well. But before we start, let us remind our viewers that we have a live discussion panel at the right lower side of your screen where they can key in your questions for our speakers. In there also, we have the polls where you can answer the polls prepared for you. The polls are already up. So if you are free, you can actually look at the polls and answer them. Okay. Dr. Usha, would you like to introduce two of our speakers this afternoon?
Okay. Thank you, Teddy. I will introduce two of our three speakers today. We are fortunate to have Dr. Meera Kurup from the UK. Very early in the morning for her, and thank you to Meera for being up and joining us. Dr. Meera Kurup is a senior consultant and pediatric anesthesia lead at the King's College Hospital in London. She has special interest in the development of safe pediatric anesthesia in low-income countries and the teaching associated with it. Our other speaker is Prof. Ina Ismiarti Sharifuddin from Malaysia, and she's a colleague of mine and a friend as well. She's senior consultant and head of the Department of Anesthesiology, Faculty of Medicine at the University of Malaya. She's also currently the president of the Malaysian Society of Anesthesiologists and the president-elect of the Malaysian Society of Pediatric Anesthesiologists. She has special interest in pediatric liver transplant, pediatric airway, and of course, TCI and Tiva for children. Back to you, Teddy.
Yeah, joining Dr. Meera and Dr. Ina is Dr. Vivian Yuen. Dr. Vivian is the Chief of Anesthesiology and Perioperative Medicine Department of Hong Kong Children's Hospital and an honorary clinical associate professor in the Department of Anesthesiology, University of Hong Kong. Her particular interest includes, of course, pediatric sedation, Tiva TCI, and dexmedetomidine in children. She will open our session this afternoon with the basic principles and tips for pediatric TCI. Colleagues, please welcome Dr. Vivian Yuen.
Hello, everyone. Thank you for having me in this Aspa conference in Singapore. Our topic today is on TCI in children, and the first talk is on the basic principles and tips. My name is Vivian Yuen. I work at the Hong Kong Children's Hospital, and I have no financial disclosure. And before we begin, I would like to ask, do you use Tiva in children? Will your answer be very rarely, sometimes only, or often is my default choice? In the NAP5 report, it was revealed that the Tiva use in United Kingdom and Ireland is only about 8%. In a more recent survey, which was on the use of total intravenous anesthesia in Colombia, only about 5% of the anesthetists in the survey reported that they always use Tiva as the choice of anesthesia. How common is Tiva in children? As it was revealed in this survey, published in Pediatric Anesthesia in 2008, most of the anesthetists claim that they never or rarely use Tiva in children, and only a small proportion of the anesthetists would practice Tiva technique on a monthly or weekly basis. So, the younger the patient, the less likely would the anesthetist be ready to practice Tiva. So why is Tiva so unpopular in children? Well, inhalation anesthesia technique is a very well-established technique. It is convenient and no IV is required for induction. It is associated with good muscle relaxation, and spontaneous ventilation will act as patient's own titration to the depth of anesthesia. You have more than 100% chance of setting up an IV successfully, whereas Tiva is a new technique. It is associated with slow recovery. IVs are often covered by drapes in more small children, and you do worry about propofol infusion syndrome. In the following section, I hope to explain to you the advantages of using Tiva in children, and I hope that I can convince you that you can also bring this technique to your anesthesia for children in your practice. In this meta-analysis of nausea and vomiting following maintenance of anesthesia with propofol or inhalation agent, it was shown that reduction in post-op nausea and vomiting was more pronounced in children than that of adults. In another study, a large randomized controlled trial on children and adults who had surgery associated with high risk of post-op nausea and vomiting, it was clearly shown that propofol is associated with much less post-op nausea and vomiting. And the volatile anesthetic were the leading cause of early post-op nausea and vomiting. The pro-emetic effects of volatile agent were more than other risk factors, including the use of anti-emetic. So in the consensus guideline for management of post-op nausea and vomiting, it was recommended to avoid the use of nitrous oxide and inhalation anesthesia and use propofol for induction and maintenance as strategies to decrease post-op nausea and vomiting in high-risk patients. In this nicely performed study on the respiratory reflex response of the larynx under propofol or inhalation anesthesia with sevoflurane with the same depth of anesthesia as it was gauged by this. It was demonstrated that vocal cord stimulation by spraying saline elicit more laryngeal spasm and apnea in children anesthetized with sevoflurane. In another prospective study on children undergoing MRI using isoflurane and nitrous oxide anesthesia or propofol anesthesia, it was shown that laryngeal spasm and airway events were more common with isoflurane nitrous oxide anesthesia as compared to propofol anesthesia. In a more recent large prospective multi-center observational study, the Apricot trial, it was nicely demonstrated that severe respiratory critical events were more common with inhalation anesthesia as compared to intravenous anesthesia. Another advantage of Tiva anesthesia would be the much reduced incidence of emergent agitation, as it was repeatedly shown in multiple clinical trials that the use of propofol anesthesia is associated with much less post-op emergence, delirium, or agitation in children, which is a common problem in children. In this study on the EEG profile during general anesthesia in children, it compared the EEG profile with sevoflurane and propofol anesthesia. And at equal potent depth of anesthesia, you can see the EEG signature is different between the two agents. And with propofol anesthesia, we see more delta and theta wave. As compared to the sevoflurane anesthesia, we see more beta wave. And as anesthesia level was deepened with propofol, you do see more delta wave, which was associated with different level of anesthesia, and this is not the case with sevoflurane anesthesia. In another interesting study on the metabolomic profile of brains under general anesthesia, we can detect that the glucose and the lactate level in the brain is higher when children was under the anesthesia influence of sevoflurane as compared to propofol. And the level of this metabolite, the lactate and glucose, is actually proportional and correlated to the propensity to exhibit emergence delirium. So you might think whether emergence delirium a clinical manifestation of anesthetic toxicity. So even though Tiva may be a new technique or is not a popular technique, it might even be difficult technique for use in children. However, there are occasions where you have to use Tiva, like when you have patient with malignant hypothermia, when you are in outside locations with no anesthesia machine, and when you have to facilitate IOM in neuro and spine surgery, or in when you have to manage a patient undergoing airway procedure. So when you use Tiva for the beneficial effect, reduction in post-op nausea and vomiting, emergence agitation, for the sake of less airway complication, less laryngeal spasm, or even less pain, you might be more comfortable when you have to practice Tiva for the patient who require Tiva technique. So when do we have to worry about propofol infusion syndrome? It is rarely documented in children for prolonged anesthesia. However, it is well documented in children in critical care setting. We have to be careful in this group of patients, and we should limit the dose to below 4 mg per kilo per hour for less than 48 hours. More importantly, we have to monitor the arterial blood gases, serum lactate, creatinine kinase, liver renal function, as well as electrolytes. EEG may give you sign of cardiac instability associated with propofol infusion syndrome, which include ST elevation as well as incomplete right bundle branch block. And when do we have to avoid propofol? I think we have to be careful in patients who are critically ill. We have to be careful in patients who are already on high-dose steroid or inotropes. And we have to limit the dose, use adjunct as far as possible, and ensure your patient has adequate glucose intake. And we do have to be careful in patient who has metabolic disease, including mitochondrial disease, because this patient has reduced ATP production and they are more susceptible to propofol infusion syndrome. And with patient who has a fatty acid oxidative disorder, they are not able to metabolize the long chain or the mid chain triglyceride. So we have to be very careful with propofol in this group of patients. Even though if you have to give induction dose of propofol, you should not maintain anesthesia with propofol in this group of patients. This is the statistic of mode of anesthesia on our patient in our hospital. As you can see, Tiva TCI use is more common than inhalation anesthesia. This might be attributed to the availability of TCI equipment. And also, when you use TCI anesthesia more often, you may appreciate the advantage of TCI and Tiva technique in children, and that will empower you to use this technique more often. And it is well established that the three-compartment model can be used to describe the pharmacokinetic of propofol in adults, and similarly, three-compartment model can be used to describe the pharmacokinetic of propofol in children. However, children has a larger volume of distribution, and then they also have immature clearance as a newborn or infant. However, the clearance of propofol mature fairly quickly with the maturation of liver function. So for young children and toddlers, they actually may have faster clearance compared to that of adults. So as a result of the increase in volume of distribution with the same loading dose, the plasma level achieved in children is lower than that of adults. And because of this, the children would need higher loading dose as well as a higher infusion rate. And because of all the difference in pharmacokinetic properties, children do have longer context-sensitive half-time with propofol infusion. So that's why they do wake up slower compared to adults. If you do not have TCI machine, you have to administer propofol by manual infusion. And these are the common infusion regimen for giving propofol anesthesia in children between 3 to 11 years old and in children under 3 years old. And comparing to the manual infusion regime for adult patients, the 10-8-6 milligram per kilo per hour, as you can see, the maintenance infusion rate is higher, 15, 13, 11, 10, and 9 milligram per kilo per hour. And this infusion regimen is associated with maintenance of plasma level of about 3 micrograms per ml in children. There is a more recent publication on the manual infusion regimen for children under 3 years of age, and this regimen was developed using a much larger number of patients and data sets, and it seems to be more reasonable regimen to use if you do not have TCI machine for children under 3 years old. In our study comparing target control infusion of propofol and manual infusion in children over 3 years of age, we have shown that the use of TCI is associated with more stable depth of anesthesia as measured by BIS. And definitely with the availability of TCI machine, it is much more intuitive and convenient to administer propofol anesthesia to children. And the most common TCI models in children include the Cattaria model and Pitfusser model. Cattaria model is suitable for children between 3 to 11 years old and over 15 kilo in body weight. The covariates of the Cattaria model include weight and age. The Pitfusser model can be used in younger children down to 1 year old and down to 5 kilo of body weight. The only covariate in the Pitfusser model is body weight. Kim's model is a model developed by a group of Korean investigators. It is a 3-compartment simple model, and it is also a PK/PD model with a KEO. The V1 of this model is fixed, so it's different from the other 2 models that we know of. The ELEVAT model is a general model where you can use it on infant, children, adult, elderly, as well as obese patients. It is a general model developed from more than 21 datasets and more than 600 patients. The model is more complicated than all the models we know of. It includes covariates of body weight, age, gender, and physical status. we were able to incorporate this model in our TCI machine so that we can use TCI on children under 5 kilo of body weight or younger than 1 year old. So much on the pharmacokinetic. So there is also difference on the pharmacodynamic aspect of children with propofol anesthesia, as it was demonstrated in this study with the same dose of or same plasma level achieved. The depth of anesthesia is different in children and adults. Children has perhaps lighter depth of anesthesia as compared to adult with the same concentration of propofol in. It was also demonstrated in this study that the younger the patient, the higher would be the CE50 or CE95. And in this study, Cateria model was used for the TCI propofol infusion. In this nicely performed study on children undergoing radiotherapy sedation with propofol infusion, either using TCI or manual infusion, it was shown that to keep patients sedated for radiotherapy, the CP for induction and maintenance was 5.3 and 4.2 microgram per mil respectively. So it seems to be a lot higher level compared to the required by adult for sedation. Remifentanil is a popular agent to be used with propofol anesthesia. So manual infusion with remifentanil can be conveniently done, and the dose is around 0.1 to 0.5 mic per kilo per minute. And remifentanil can be given by target control infusion on children who are older than 12 years of age and weight more than 30 kilo. The Minto model is the most commonly available model for TCI remifentanil. So there are a lot of things to consider when using TCI in infants and children. We have to consider the age, maturation of propofol metabolism, the size of patient, PK and PD parameters. After all, there would be large inter-individual variability in propofol requirement. It has been shown in adults, and this would be the case for children as well. Therefore, after all, titration to the clinical need of your patient and vigilance would be the key to safe delivery of propofol anesthesia. Before we move on to the cases, I would like to ask you if you think Tiva TCI in children is difficult. Yes, definitely. A bit that I will try, or no, I think I can master. Thank you.
Thank you very much, Dr. Vivian, for that informative talk, an excellent refresher for our experienced viewers, and probably something new for our trainees. Gentle reminder to everyone to please key in your questions under the live discussion box. And we have a poll questions there as well. Later on, we will discuss towards the end of the panel. So, Dr. Vivian, in your experience, I think I'll also ask Dr. Mira and Dr. later. How difficult, how easy for trainees like fellows or residents to learn and appreciate Tiva TCI in children? And what are the common pitfalls or hurdles you encounter for them to not use or use more the TCI or Tiva TCI protocol? Yeah, Dr. Vivian?
Thank you for the question. In my experience in our center, because we are readily equipped with TCI machines for children, so we have the models and the machine so far enough for our cases. So it's quite easy for trainee to adopt the practice as long I guess trainee usually go along the practice of the senior. So in our center, as I have shown just now in our statistic, about 70% of the OT cases are done under TIVA or TCI. And then there we do some sedation in OT, right? And most of the sedation outside OT will be intravenous anesthesia. So it might be propofol or dexmedetomidine-based sedation. So in our experience, it's quite easy for them to absorb, maybe because of the equipment or because the senior are practicing this technique quite a lot. So I have not actually surveyed or asked them whether they like it or not. Maybe they are coerced because the seniors are using it. So it might be interesting survey to perform.
Yeah. How about in Malaysia, Dr. Ina? I think you're muted. Yeah. Can we hear you? Yeah. Dr. Ina?
Okay, thank you, Teddy, for the question. In Malaysia, I think in my center, it is a tertiary center and center for teaching, training for Masters of Anesthesia. Initially, we Tiva in pediatrics, not the main core subject that we teach our trainees. However, the adults Tiva is one of the main core subject, but if they have been comfortable in using it in adult, then they will transition to using Tiva in children. But of late, we are going to put this because Tiva in children has been widely used worldwide compared to previously. We are now incorporating it into our curriculum. So hopefully it will be more well accepted. However, I do say that although we have the TCI machine and it's easily available, but the drugs like remifentanil is a little bit on the pricey side in Malaysia. So it does limit the use of Tiva in children. However, it is taught because when you really need to use it and there's an indication, they must be comfortable to use it. So yeah, I think as long as they understand the pharmacokinetic models, the difference and the indication, I think most our trainees are quite comfortable to do it.
Yeah, thank you, Dr. Ina. How about in UK, Dr. Mira?
The use of TCI hasn't been included in the curriculum, but we are in the process. So the trainees, it is coming that trainees need to do a certain number of cases just to be familiar with it.
I see. Noted on that. I'm scanning through the questions from the chat room, but before that, I will give the floor to Dr. Usha to share the results of our polls. Dr. Usha, would you like to share the poll results? Thank you.
Yeah, thank you, Teddy. So we had two poll questions. One was, do you use Tiva in children? And 15% answered very rarely. 85% said sometimes when indicated. All right. And the second question is, Tiva in TCI in children is difficult. And 25% said yes, definitely. But 50% said no, I can master it. So what do you think, Vivian? I think it sounds positive. Looks like a lot of folks are using it and getting used to it, isn't it?
It's very encouraging.
Yeah, that's good. So I think I think where trainees are concerned, they still need a lot of guidance where this is concerned, and it takes some time and some practice and regular use to actually have good, learn the right thing. Correct. So are we doing?
Yeah, we have questions here. We have questions from our chat questions box. Actually, Dr. Vivian, a lot are actually interested with the L-Weld model TCI for young children. So they're asking whether is it available? Can we purchase this? Can we include this in the current module that we have? Because it sounds very interesting and promising for younger infants as well.
Yeah, for kids under 5 kilo and under 1 year old, I do use the Alivet model. And for the obese kid, like when they are 8 years old and like 30 something, 40 kilos or something like that, we do have it in our palm. If the delegates are interested, they can send me email so that I can tell them what machines are. For my knowledge, I know there are 2 machines that has this model available
Yeah, all right. Thank you for that.
commercially.
And,
Yeah.
yeah. And another question from Dr. Satish. He asked whether do you keep track of dosage, like in milligram per kilogram per hour with TCI and all the Tiva models in all patients, keeping in view propofol infusion syndrome. Do we actually track or trend, especially if you're doing a long case and you are in propofol infusion? Dr. Vivian?
Oh, I
Yeah.
thought it's for, yeah, okay, I can. We do have, I mean, on the machine there is the total dose, as well
Mhm.
as on our electronic record. But to be honest, I do not consciously calculate for ordinary anesthesia case. For a long case, I try to titrate down and use adjunct, so that I can control the dose of propofol, especially long and painful case. I will add in infusion of desmethyltomaline and make sure I give good analgesia. So I decrease the propofol as the case progress. So
All right.
maybe Mira and Ina can also comment.
Dr. Mira?
Okay, so when I started using TCI and my cases went into 12 and 14 hours, I used to record the amount of propofol that we have used in my electronic chart. But a propofol is fast metabolized, and if your base deficit and lactate are normal, I do not. Now I do not, because if there by any chance, so far I haven't encountered that. If the base deficit is low and lactate is high, then it's better we need to, so that we can keep track on. This is for longer cases. For shorter 2 to 3 hours cases, I think we should not worry. What do you think, Dr. Vivian and Dr. Ina?
Yeah, agree. So yeah, for long case, I do check the blood gases, the lactate level. So if I really worry, if the patient go into metabolic acidosis, I think I remember I had instance where I switched to the CFO because the patient bled a bit and he's already acidotic. Yeah, but it's quite rare. But yeah, monitor is the key and use adjunct to decrease the dose of propofol.
Okay, I'm giving one last question before we move on to the next speaker. So this one is from Dr. Melody when she asked, do you find that there is a longer time to awakening with Tiva techniques compared to inhalationals like sevoflurane and desflurane? And do you have tips to reduce the hangover effect that can improve our turnover time? Yeah. So the question is mainly comparing inhalational versus Tiva when it comes to recovery. Maybe I will start with Dr. Ina first.
Okay, thank you, Melody, for the question. I actually think it depends on the experience and practice, actually. It's just like, I think most of us are very comfortable at switching off our sevoflurane just by looking at the MAC, And with Tiva, you need to be more caution when to reduce it by looking at the plasma concentration at that point. And by default, which I will explain later in my lecture, it's you have to know when to time it accordingly to let it the plasma concentration in the blood to come down to 1.2 mic per mil at that point where it is shown that patient normally would wake up. So I think it just needs practice because you're now out of your comfort zone of turning down the sevoflurane. Yep.
Yeah, just like what Dr. Vivian mentioned earlier on, titration is the key and you need to use it more. Yeah. So I think we are ready to move on to our next talk. Dr. Usha, would you like to carry on, please?
Yes. Thank you, Teddy. Our next topic is by Prof. Ina, and please welcome her with her topic of TCI for the anxious child coming for ambulatory surgery.
Hello and Assalamualaikum everyone. Thank you Aspa and the organizing committee for the invitation to share my thoughts in this symposium. I'm Ina, a consultant anesthesiologist in University Malaya Medical Centre, Malaysia. Today, I will share with you my experience in providing Tiva for an anxious child coming for ambulatory surgery. You're in charge of the daycare surgery today, and you were informed that you have a 3-year-old boy scheduled for right orchidopexy in a daycare surgery. He has no significant past medical and surgical history. However, Mom has history of PONV and says her son might have some motion sickness as he get nauseated and vomited after being in a long car ride. Otherwise, systematic examination is unremarkable. You plan to do a Tiva technique on this patient. However, you are faced with a very anxious child. It is impossible to start an IV access, but you know this patient will benefit from Tiva. So how would you proceed? I will be speaking on this agenda. Why Tiva in children? How to manage anxious children prior to Tiva, and I will touch a little bit on propofol and remifentanil, and then demonstrate the use of Tiva in this child. The goals in managing pediatric day care cases are to have a patient that wakes up well at the end of the surgery, with a short and a quality recovery time. They should have good pain control and minimum PONV. This will ultimately allow for rapid discharge from the hospital. So why Tiva in this child? If you look at this case, this boy has 3 risk factors, which is age of 3 years old, history of motion sickness, and family history of motion sickness, and a surgery that lasts more than 30 minutes. Thus, he will be classified in the high-risk group of getting PONV as outlined by the 4th Consensus Guideline for the Management of PONV, which was published in year 2020. This is the simplified risk score from Ebert et al. To predict the risk for post-op vomiting in children. The number of risk factors correspond to the risk of getting post-operative vomiting. In this child, he has 3 risk factors, so the chance for him to get post-operative vomiting is about 50%. From this 4th Consensus Guideline, it is shown that Tiva, along with liberal fluid therapy and opioid-sparing techniques, is good in reducing baseline risk for post-operative vomiting in children. However, it is a challenge to start a Tiva in anxious child, and children can be anxious for various reasons. First of all, children might be anxious due to their age. Children between the age of 1 and 5 years old are at the highest risk of experiencing severe preoperative anxiety. Secondly, children can be shy and inhibited. Children with this personality are more prone to be anxious at induction of anesthesia. Thirdly, children can be anxious because of previous traumatic hospital experiences. Many children have to come to hospital for repeated admissions and procedures before, and any bad experience can lead to anxiety in the current hospital admission. And last but not least, a child can be very anxious because the child have a disability that prevents them from understanding and coping well with new experiences. This can be due to the child having a hearing and visual disability, or a speech and physical disability, or learning and mental disability. After identifying the child at risk, we can then manage their anxiety prior to induction of anesthesia with behavioral or pharmacological interventions or both. Examples of behavioral interventions are parenteral presence during induction phase, preoperative preparation with preoperative operating theatre visit with play therapies, perioperative music, or in some situation, we might need to decrease the sensory stimuli such as needed by children with autism. In most children, behavioral intervention is sufficient to reduce anxiety. However, this might not be suffice for some. In this situation, we can provide pre-medication for them. If behavioral intervention does not help, then I will consider using some sedative agents for pre-medication. Some of the drugs that I use are midazolam and dexmedetomidine. Midazolam is one of the most commonly used pre-medication in children. It has the advantage of having an imidazole ring, allowing for easy absorption across mucous membranes. It can be administered via multiple routes including oral, intranasal, and rectal. I would normally prescribe it as oral. However, given orally, midazolam can have unpleasant taste, and I often combine it with sweet carrier agents such as syrup paracetamol. The onset time is about 20 to 30 minutes. Administration via intranasal route can sting and normally not tolerated by children. The advantages of midazolam, apart from providing sedation, are it provides anxiolysis and antegrade amnesia. The next pre-medication drug we can use is dexmedetomidine. Dexmedetomidine is a selective alpha-2 receptor agonist. It provides sedation, anxiolysis, and analgesia without any respiratory depression. However, if given in a large dose, it can cause bradycardia and hypotension. But this applies mainly for dex given via intravenous route as shown in the next paper. In this study, we look into the different doses of dex used intravenously in several randomized controlled trials, and we found that low-dose dexmedetomidine, i.e. a dose less than 0.5 mic per kilo bolus, demonstrated better hemodynamic stability than larger dose of more than 0.5 mic per kilo bolus. Dexmedetomidine can be used as a pre-medication for anxiolysis with a dose of 1 to 2 mic per kilo given intranasally as we had shown in this paper. In this study, we showed that in younger age group, dex in a dose of 1 to 2 mic per kilo produced satisfactory sedation, and in older children, the dose of 2 mic per kilo gave better satisfactory sedation. The onset time is about 25 to 30 minutes. But this pre-medication is just to facilitate the application of mask for induction. We still need to use amla cream for insertion of IV cannula if we want to do a pure Tiva. So how do I perform Tiva in anxious children? Let's watch my short video in which I will demonstrate two scenarios in which both child was scheduled for orchidopexy in my daycare center. In the first child, who was mildly anxious but cooperative, I applied an amla cream prior to inserting a cannula. With parental presence and a gadget to divert the patient's attention, I then started my full Tiva with remifentanil followed by propofol. In the second case, the child was a very anxious child and was clinging to the mum. So I gave him a pre-medication with oral midazolam and allowed parental presence and started my anesthesia with gas induction prior to obtaining IV access for my Tiva. Outside, we feel a bit, we would not be cooperative, so I'm going to reduce anesthesia and then gas. Okay? So I think and propofol lower to 2.5 or 2 depending. Normally lower than 2.5. You may notice I don't use this because this is a surgery where we put LMA and we do not paralyze patients. So the risk of awareness, if any, is the vein move a little bit or you will get all the symptomatic response. So I don't typically use this in this case. Things to note from these videos are, for the second case, after a gas induction, we can start the TCI propofol with lower plasma target concentration. Instead of the usual 4 to 5 mic per ml for the plasma concentration, we can use a loading dose of propofol 3 to 4 mic per ml. For maintenance, I will target my plasma concentration in between 2.5 to 4 mic per ml. I use a proglottic airway device to maintain the airway. In this case, I requested the surgeons to give the ileoinguinal block via direct vision, hence I can further lower the dose of remifentanil. I did not use any neuromonitoring such as BIS because I do not paralyze this patient. For antiemetic prophylaxis, I still give a dose of dexamethasone and ondansetron. Just for those who are wondering, I don't normally have that many assistants on daily basis. As noted from the video, I use mass infusion rate with remifentanil. If I plan to maintain the spontaneous respiration throughout the operation, I will have to introduce remifentanil gently, and the best predictor that a child is going to be apneic soon is when you have reached a respiratory rate of 10 per minute, at which I should reduce the dose of remifentanil infusion. Younger children, especially those aged less than 3 years, tolerate a higher dose of remifentanil while still maintaining spontaneous respiration. Now I would like to show you how I will wake up the patient after the procedure in daycare. It depends whether you want to remove the supraglottic airway device deep or awake and depends on your PACU policy. Here, I plan to remove the SGA awake. I will stop the propofol earlier as it takes a bit of time to reduce the plasma concentration to 1.2 mic per ml. This is the level that patients are normally expected to be awake, just like your MEC awake of 0.3. Then, I will stop the remifentanil at dressing, ensuring that I flush the line well. So make sure you have flushed the line that you use to
run your Tiva just now. Because when you have failure, even in a small dead state, if it goes into the circulation, can cause apnea. Moving on. Okay. You look here. It's 1.3. They put about 1.2 patient wake up, but you can see now that 1.3 patient is actually waking up. So we just wait for patient to
To conclude, a rapid clear-headed recovery after Tiva with a low incidence of nausea and vomiting is the attractive prospect for the use of Tiva in an anxious child in daycare surgery. And there are many ways to approach this group of anxious child for Tiva. Familiarity with the technique is required, and we just need to learn to do it. At the end of the day, the choice is yours. Thank you for your kind attention.
I think we're back. Thank you very much, Dr. Ina, for that very interesting talk, very informative. Before we ask the questions, we will go to discuss our polls first. So Dr. Ina asked a poll question to our audience. The poll question is the dose of propofol for TCI used for maintenance of anesthesia after a volatile anesthetic induction in same dose as when you use the full TCI technique. So she asked true or false, and 84% of our attendees answer false. So what is the correct answer, Dr. Ina? Can you share with us?
Very clever audience. They answered excellently.
All right, excellent. I think there are a lot of questions here, but I will go and discuss, share first the first question by Dr. Senehalata. We're in because in the case that you shared with us is a little bit older, but he is asking what is the recipe of Tiva for baby of 10 months for orchidopexy along with caudal block. So maybe same procedure, orchidopexy, but a little bit younger patient, 10 months old. So they're asking for a recipe. Would you do the same thing, same technique? Because I saw that you run remifentanil and you run some propofol together with the remi. So do you do the same combination for a 10-month-old?
Yes, I will. Because Pitfusor can be used for children, although it's written there in the protocol for children more than 1 year old, but the weight is more than 5 kilos. So I would definitely use it in a 10 months old baby with a weight more than 5 kilos. Yes, and the way I use it will be the same. And depending whether I use it awake or after gas induction. And if I were to give caudal earlier, then I can titrate my propofol and remi quite faster to appropriate level.
All right. Okay. Noted on that. So thank you very much. I have another question. I think this one I'll ask all for our three speakers. You mentioned, Dr. Ina mentioned earlier on about pre-medications for child with special needs. And she mentioned about Precedex or dexmedetomidine. And we all know that, yes, we highlighted that Precedex, dexmedetomidine is very effective and all that. But one of the issues, especially for developing countries, wherein the price of dexmedetomidine could be a little bit expensive. And there are some who are asking whether can we consider clonidine as a replacement for dexmedetomidine for pre-medication in combination with midazolam for children with special needs. Maybe I'll start with Dr. Ina first. What do you think, Dr. Ina? Yeah.
Thank you, Teddy. I personally don't have the experience with clonidine. In my center, we don't have clonidine, but it was just introduced to Malaysia about 1 year. I think I've just knew that it's now in Malaysia from my colleagues. From the Ministry of Health, but we don't have it in the Ministry of Education Hospital. However, if you look at the pharmacology of the drug, the mechanism of action is still the same. It's an alpha 2, it's a selective alpha 2 agonist. And however, dexmedetomidine is more alpha 2 selective. Hence, the sedative part of it is better with dexmedetomidine. However, but you still can use clonidine with the same sort of need, and there are literature out there that says it can be used. I'm not sure if Dr. Mira and Dr. Vivian, you have experience with
Dr.
clonidine?
Mira, how about you? I think you're muted. Yeah, can we unmute Dr. Mira? Yeah. Yeah,
Can you hear me now?
Yeah,
I think clonidine can be used, clonidine can be used preoperatively with MEDAS or on its own. MEDAS, in our institution for pediatrics, we will not go above 10 to 15 milligram for midazolam in total for pre-medication. So if the child needs more than that, we add clonidine or dexmedetomidine. And post-operatively also, we use clonidine, especially in a long case, to compound the action of post-op analgesia. Sorry, I'm moving away from pre-op. Sorry.
Can I ask also, if you're using clonidine, what dose do you usually use? Is it the same as your dexmedetomidine?
2 mics per kilo? Yes, thank you.
Okay. Dr. Vivian, how about you?
I don't have clonidine in my practice. I don't know why, but we don't have experience using it as a pre-med. So for special kid, where they don't take nasal drugs or even oral drugs, sometimes we may have to revert to IM. IM either dexmedetomidine plus ketamine. Yeah, that's what I do. But most of the time we try and give it nasally, or even if I have to give it orally, see what the kid will take. Yeah, but I don't have experience with clonidine. I guess it will be a longer acting drug. So for a long case, it will be fine. But for a day case, it may really slow down your discharge time.
I see. Yeah, noted on that. Another question from our viewers. I think this one I'll ask Dr. Ina. I think one of your case, right, you shared with us an anxious child with no IV. You started with gas induction first, then you convert to Tiva following that. There's one question from Dr. Gyok Moy Tan. If inhalational induction and then TCI propofol, do you still see less nausea vomiting for this group of patients as compared to gas alone?
Of course, it is also, you have to look at a multi-modal approach. It's not just the gas or on the Tiva, but also the pain relief that you're going to give. So all in all, we are trying to use opioid sparing technique and Tiva on top of it to reduce this PONV.
All right. Okay.
Yeah,
and
but definitely, and even if you're going to gas induce, make sure you don't bag excessively.
Yeah.
Don't use nitrous and bag excessively, because all that will lead to PONV.
Yes, correct. I agree with that also. Last question before we move to our next speaker. They are asking regarding pain following propofol. So they said some of the viewers mentioned, what is your suggestion? Because some of them use lignocaine, some actually run certain opioids before. But with lignocaine, they still think that there's still some reaction due to pain. So Dr. Vivian, what do you usually do for children, especially if you're inducing with propofol?
To be honest, we do a lot of gas induction, even for TCI maintenance. So that alleviate the problem. And if I have to do TCI induction, I give lignocaine IV. But if the situation allow, I get someone to hold the child's hand to act as a tourniquet when the lignocaine is given, so that we try and keep the lignocaine in the veins. Then I start the propofol infusion and release the hand and just gently restrain the hand while the drug is being infused. So whether that helps or not is hard to know, because it's also hard to really know how painful with and without the lignocaine. And I do see patient respond to lignocaine injection as well, so it might itself be painful to inject.
Yeah. How about you, Dr. Mira? What's your technique for pain?
Okay.
Yeah.
Okay, it will come in my presentation. One is give the narcotic before the propofol and wait for a minute, keep talking so that they will get chilled out. Then definitely use lignocaine before propofol. I'll try your hand squeezing technique, Dr. Vivian. Thank you. Always forget.
I also squeeze the hand.
Yeah.
Like a tourniquet,
kind of thing. Always forget when you're pressing the buttons, you forget to squeeze the hand.
Yeah. Especially if you don't.
That's why I say when situation allows, sometimes induction is a little bit messy with parent and the assistant. Yeah.
All right, I think we can move on to our next.
Yeah, that's what I was. I had some experience with as well, being told to just apply like a gentle tourniquet, give the lignocaine, and follow up with the propofol. Sometimes it works, sometimes it doesn't. Yeah.
Then did you also give some opioids before you start, Dr. Usha? Oh, okay.
Yes, I would.
Yeah.
I would give at least the fentanyl. Or,
Yeah. All right.
Distraction,
okay.
I think distraction also works. As I keep talking, let them focus on a video or something like that. When they feel the pain, you say, "Oh, this is going to be cold," and it's cold up to your head. Then when you feel sleepy, so something you say or
pharmacologic approach.
Yeah.
I think
anyway, the phone is the best gadget, I guess.
I think now we've got YouTube, like on the handphone and all that. That's a good distraction for them if you already have the line. So, and definitely narcotics prior to.
Thank you very much for all your feedback. So we move on to our next speaker. We will welcome back Dr. Vivian, and he will going to share with us a case, infant coming in for and this airway endoscopic assessment. Dr. Vivian, please. Thank you.
Hi, in this session, I would like to present a case using Tiva TCI for an infant coming for airway endoscopic assessment. This is a 2-month-old boy, 3.5 kilo, with history of stridor. We suspected he might have laryngomalacia, and he's booked for a flexible and rigid laryngotracheal bronchoscopy with supraglottal-plasty if indicated. He's otherwise healthy, and there are other conditions requiring laryngotracheal bronchoscopy, including subglottic tracheal stenosis, hemangioma, papilloma, laryngeal cleft, vocal cord lesion, or foreign body retrieval in older kids. So what would be your preferred anesthetic technique for endoscopic airway assessment and intervention in children? Would you prefer propofol-based intravenous anesthesia, or sevoflurane anesthesia, or other? The ideal technique will be a technique that allows you to maintain oxygenation and adequate ventilation. And I prefer to keep the patient breathing spontaneously. And yet I will allow the surgeon an unobstructed surgical access so that they would be able to evaluate the dynamic airway function and airway obstruction through the flexible and rigid laryngotracheal bronchoscopy. And we will try to achieve a stable surgical condition with no laryngospasm and no interruption. Of course, we do not want to create pollution by inhalation anesthesia, and we want the depth of anesthesia to be adequate and adjustable. Delivery of anesthetics should be independent of the airway. Of course, you want rapid emergence. So my choice of anesthesia would be propofol-based anesthesia. Apart from propofol, I would use adjuncts. Remifentanil is the first adjunct of choice in my practice for this kind of procedure because it obstructs the airway with good antitoxic properties. It reduces coughing and gagging during the airway manipulation. It is very easily titratable with very short contact-sensitive half-time despite of the duration of infusion. In this study on young children undergoing upper gastroendoscopy, remifentanil infusion was given at 0.025, 0.05, and 0.1 mic per kilo per minute, and the use of remifentanil reduced propofol dose requirement. And there is no benefit increasing the dose beyond 0.025 mic per kilo per minute when propofol was used for upper gastroendoscopy. I suppose when the dose is higher, the rates of apnea or bradypnea or hypoventilation would be increased. In another study on young children undergoing dental procedure with sevoflurane anesthesia, it was reviewed the median tolerated dose of remifentanil for kids undergoing sevoflurane anesthesia with spontaneous breathing was 0.127 mic per kilo per minute. So a higher dose would cause apnea. And the predictor of apnea was respiratory rate less than 10 per minute. This study was designed to find out the tolerable dose of remifentanil to maintain respiratory efforts in kids from 6 months old to 9 years old. And it was revealed that for kids undergoing strabismus surgery with propofol-based anesthesia, the RD50, which is the infusion of propofol causing 50% of the study group to have respiratory depression as defined by respiratory rate less than 10, was lower as the kid is older. So younger kids tolerate a higher infusion rate and older kids tolerate lower infusion rate of remifentanil. Another adjunct I would use is dexmedetomidine. It is a highly selective alpha-2 agonist. It's a unique sedative that is different from most other sedative anesthetic agents because it has sedation effects that mimic natural stage 2 sleep with minimal or no respiratory suppression. It is associated with rousable sedation with very mild analgesic effect. In this study on a large group of children undergoing Tiva anesthesia for retrieval of foreign body in the airway, propofol was maintained at 200 mic per kilo per minute for the procedure, and the children were randomized to receive either dexmedetomidine or remifentanil. When they had dexmedetomidine, they had 4 mic per kilo loading dose followed by 1 mic to 2 mic per kilo per hour of infusion, whereas the remifentanil group received 0.05 mic per kilo per minute infusion, and it was titrated to respiratory rate. Both groups showed similar desaturation, bucking, and light breath holding rates. And compared with remifentanil, dexmedetomidine propofol Tiva anesthesia provide a more stable respiratory and hemodynamic profile, but it requires a longer recovery time. Very often this patient comes in with no IV and you don't have a TCI model that will work for this baby. So I usually do gas induction with sevoflurane, allow an IV to be placed. And then we start Tiva manual infusion. I will start the propofol infusion at about 10 to 20 milligram per kilo per hour after sevoflurane induction. I stop the sevoflurane after an IV is placed and the infusion is commenced. And I usually start at a lower dose and gauge what my patient need for the procedure. I also start remifentanil at about 0.05 microgram per kilo per minute. And some kids might need higher dose, but very rarely I would go over 0.1 microgram per kilo per minute because I want to keep the kid breathing spontaneously throughout the procedure for assessment and for also maintaining ventilation and oxygenation. And with the availability of dexmedetomidine, I also add dexmedetomidine to the infusion, and I would load the patient with 1 microgram per kilo, and then I would start an infusion at 1 microgram per kilo per hour throughout the procedure. With the use of dexmedetomidine, it is much easier to titrate propofol to the depth required. So the only variable during the intervention and examination would be adjusting the dose of propofol. And when you use manual infusion, how do you deepen anesthesia? You might need to give a bolus of propofol and increase the infusion rate if the depth of anesthesia is inadequate. So with bolus administration, you can either give it manually with a separate syringe, and for this baby, I would have it drawn up in a 2.5 ml syringe. So every time I only give half a ml, 5 milligrams, so it's a little bit over 1 milligram per kilo for this baby, and I observe for the response. Of course, after a bolus, I might need to increase the infusion rate as well to ensure that the depth of anesthesia required is achieved. So after you increase transiently, you might have to come back down depending on the depth of the patient. You might also give a bolus dose of propofol conveniently with a smart pump because you already have your propofol infusion linked up with the patient. So the following video will demonstrate how to give a bolus propofol with an infusion pump. This is just another short video to show you how to use a smart pump to deliver bolus propofol during a manual infusion. So as long as you know how to operate your pump and program it, it can be used quite conveniently for delivery of manual infusion and deepening of anesthesia using the same system without requiring an additional syringe of propofol. We also prepare topical anesthesia for the procedure. Usually because they are quite small, the dose is quite limited by the body weight. So I dilute the niclocaine to 1%, and I would draw up the niclocaine that is tolerated or allowed for the patient in a 2.5 ml syringe. So with this niclocaine, I share with my surgeon. So I will topicalize the pharynx and larynx with direct laryngoscopy. And to give the niclocaine, you might use a long cannula, or you can also use an atomizer that will allow a nicer spread of the niclocaine to the airway and below. So we always talk about titration to the depth. So how do we judge that the patient is dipped enough? As we give the topical anesthesia, it is a juncture where you can gauge whether your patient is dipped enough. Oftentimes when they become deep, they will have decrease in respiratory rate and they breathe regularly under the influence of Tiva anesthesia. And then when you do direct laryngoscopy for the topicalization of the airway, your patient should not move or respond to the direct laryngoscopy. So very often for the first time when you do a DL, the patient might move, so that you know that you need to deepen the patient more before you try again. As you do the DL, you also listen to the heart rate on the monitor, and if there is no change of heart rate with your direct laryngoscopy, you know your patient is adequately anesthetized, and you can pass the patient to the surgeon for subsequent examination and surgical procedure. If you have TCI machine for this patient, and if you have the Elevate model available, it is much more conveniently to use TCI propofol infusion with addition of the remifentanil and desmetanide. So with the Elevate model, I usually titrate the plasma level required by the patient. I start at maybe about 4 ml per ml and then titrate up as required throughout the procedure. And for the rest of the procedure is more or less the same. And again, titration is the key. And during the procedure, because the surgeon has the airway, you don't even have capnography for monitoring of breathing. However, you do see patients breathing through the surgical field. So as you can see, the vocal cord is moving with breathing effort, and the surgeon is trying to do examination and intervention. On the other hand, you can also appreciate patient's breathing effort by putting your hand on the patient's tummy, so that you will detect patient's breathing, and you also will be able to detect apnea early. So this is another video showing a repair of laryngeal cleft. So with this technique, you are able to maintain spontaneous ventilation and allow surgical intervention. Some tips about induction with TCI propofol. If you do induce with TCI propofol, you have to, of course, ensure your IV is functioning and also securely taped to the patient. And instead of putting a face mask on the patient like when you have to do gas induction, more importantly, you need to make sure that your patient's limb with the IV is not moving, because it's not uncommon for the patient to move in response to TCI induction. So you would apply gentle pressure on the limb with the IV. Make sure when you try and induce with propofol, the drug is delivered to the patient. And what happens when you encounter movement or laryngeal spasm during the surgery? So you have to figure out why. Is that because of inadequate depth, inadequate analgesia, or is it secondary to a non-functioning IV? Because this IV might be kinked, occlude, dislodged, or even there might be extravasation. So you have to examine your IV before you act. And what to do? You might have to withhold surgery, stop the intervention, and allow you to deepen anesthesia. If you are using TCI, you may raise the CP level quite conveniently on the machine. If you are doing manual infusion, you may need to give a bolus either with the machine or with a separate syringe, followed by increasing the infusion rate and titrate to effect. Sometimes you might need more analgesia or topical anesthesia. It is not uncommon for your small patient to be totally covered under the drapes, including the IV, so delivery problem may go unrecognized. So you have to have good hardware and good preparation to make sure your delivery of Tiva is not affected or is not interrupted during the procedure. You have to be cautious with problem arise from the IV, and it really relies on a good infusion pump where you can judge the pressure change quickly with if there is problem arise in the system. And vigilance is really required for a successful Tiva or TCI delivery. So if you do have to use old syringe pump for manual infusion, I still will try and pair up this pump with a sensitive and new pump or smart pump, so that whenever there is a problem with the system, at least one of the pump will alarm. And of course, you have to make sure when you connect all the infusion together, the infusion will go to the patient instead of to each other. So you use anti-reflux valve or some infusion sets which allow you to deliver propofol and intravenous anesthesia to the patient with no problem. I hope this has give you some insight on how to give Tiva or TCI to a small kids for airway procedure, and we welcome questions after the talk. Thank you.
Thank you very much, Dr. Vivian. For me, adequate depth, adequate topicalization, and keeping the patients spontaneously breathing are my takeaway from the case. Yeah, so I think I have one of the main concerns, I think even our viewers, is the apnea from propofol and in combination with remifentanil. I understand that you recommended, based on your talk, Remi should not go more than 0.1 microgram per kilogram per minute. So question now, Dr. Vivian, if at any point wherein the patient hypoventilate or turns apneic, how will you actually, what's your immediate response to this? What's your immediate titration with this hypoventilation issues? Which one do you cut down first? And then if you're going to cut down, you cut down by how much? So just a quick tips to our viewers. Yeah.
I often keep the remifentanil at around 0.05 and then titrate with the propofol. So if I have to cut down, I will cut back the propofol dosage. Yeah. So also I add desmethyltomidine to the mixture for this kind of procedure. So along the case, I also gradually cut down the desmethyltomidine infusion rate.
I see. But if you cut down, by how much do you usually cut down? How much do you usually cut down at any point in time?
If I'm using TCI, just 0.5 ml per ml every time, and see. If I'm using manual infusion, it's just intuitive. Like if I'm running 50 milligram per kilo per hour, you know, I just cut down by 2 milligram per kilo per hour and see. Yeah.
I see. Okay, Dr. Mira, do you do the same thing in terms of titration for airway endoscopy for hypoventilation applications?
I don't routinely do airway endoscopies, but when I was a trainee and I was using this, it's the same. Keep one, especially because this is a spontaneous breathing patient. So it's easy to titrate the depth of anesthesia. When I say easy, relatively easy to titrate the depth of anesthesia. Keep Remi stable, play with the propofol or dexmedetomidine, and vigilance. Look at the respiratory rate and depth all the time. Yeah.
All right. I think Dr. Usha, you want to share the poll results first?
Yes. So the poll question we have here is what is your preferred anesthetic agent of choice for infants and children coming for endoscopic airway surgery? And 86% answered Tiva with propofol. So I think we're doing well. We can actually end this session since everybody is getting it right. Anyway, that's good. So Vivian, would you like to comment or say anything about that?
Oh, I think that's very, very good, encouraging. Yeah.
Okay, that's good. Okay, one burning question I see in the chat is, how would you time pre-medication with midazolam? Maybe I can have feedback from everyone.
Yeah, we start with Dr. Ina. I think that's part of her talk later on. Yeah.
How would
Regarding
you time the pre-medication with midaz?
Midazolam, as I said, the onset is about 20 to 30 minutes. So you have to call in early the patient to your to your reception area. And we normally, if I want to give midazolam, I would give it in our reception area where I can observe the patient, and I normally give it about 20 minutes to 30 minutes prior to my induction.
I see. I think 20 minutes is the magic number even for us.
Yeah.
So I have another question here. If, let's say, for example, right, given the same case, patient coming in for airway endoscopic assessment, but the patient is obese and BMI is on the high side. So the question now from our viewers, will you change your plan for sedation, your options or your choices? And are you going to compute your doses based from lean body weight or, So I think I'll start with Dr. Vivian first with that question. If, let's say, this patient BMI is on the high side, so how will you actually, recalibrate your plan and technique and approach for this?
You mean obese kid for airway examination?
Yeah.
I don't come across this scenario, so I have to.
Maybe if, let's say, for example, for some other procedures, but the patient.
Obese. Wow.
How do you usually?
Very convenient for me now. If I have the Elevate model, then I just use the Elevate TCI. In the past, for obese adult or obese kid, then I have to. I would monitor definitely even for a short procedure in terms of EEG, BIS or Z line. So I think for adult, the adjust body weight might be better. So it take into consideration the total body weight and ideal body weight. So adjust body weight is a little bit higher than the ideal body weight and less than the total body weight. So it's like a compromise. So I would rather use adjust body weight for an adult. But for kids, I don't know how. I think I would use a similar approach. So there's something in between the ideal and the total body weight to use the menu infusion or the TCI if I don't have the Elevate model.
All right. Dr. Mira, what for you? Yeah.
So the induction dose usually goes to total body weight.
Yeah.
Then for maintenance, so might be better to use 2 pumps for the induction and the maintenance. So because when we dial in the weight, it stays there, isn't it? So it might be better to use another pump for the maintenance, especially if it's a long case. You definitely have to reduce to lead body weight or ideal body weight. Not ideal body weight, the adjust to lean body weight. And you are talking about airway case.
Yes.
Teddy? Yeah. Then it's easy to monitor because of the respiration. And not major painful stimuli. Then it's easy to monitor. So start with a higher dose, come down and monitor respiration and the depth.
I see. Yeah, noted on that. I think there's a couple of questions here. If at any point that remifentanil is not available, right, they're asking whether can they use alfentanil or can they use ketamine plus ketamine as a replacement or dexmedetomidine. So they're asking for replacement for remifentanil if it's not available. Have you tried using alfentanil, Dr. Ina?
I've used alfentanil many years back, Teddy. Not recently with this Tiva TCI in children because we don't have the pharmacokinetic model for it.
Yeah, correct.
And I think it's very difficult to titrate with alfentanil for the respiration. So I have no experience.
Okay. Anyone from our speakers who have used alfentanil recently, or yeah?
I use alfentanil, but for a Tiva, I will use a bolus dose or a longer acting opioid only if the patient is breathing spontaneous.
Okay.
For any case which the muscle relaxant is used, maybe people can argue that with the BIS we can use ketamine or alfentanil. I don't have the experience. I have used alfentanil or boluses of ketamine with propofol for spontaneously breathing cases, especially when I go outreach and need to do a TIVA because of some peculiar situation, especially the airway cases.
So if you use ketamine, you use it as a bolus dose.
As a bolus. I haven't used, as a bolus
Give
intermittently.
any anti-sialagogue or anything that, just in case, because since it's an airway surgery, if you're using ketamine.
Say that again.
Do
Sorry.
you use any anti-sialagogue like glycopyrrolate for if you use ketamine, or you just
Definitely.
give it? Okay.
Definitely. Yeah.
I see. So I think there's another question here regarding the use of local anesthetics. They are asking whether, I think this is from Dr. Serpil, does the topicalization of the airway cause aspiration of the secretions at the end of the surgery? Yeah, Dr. Vivian? Yeah, because we discussed earlier on that you use local, lignocaine, right? Lignocaine spray as part of the analgesia component. She's asking whether the topicalization of the airway can cause, do you have any reports or cases wherein ended up with aspiration after the surgery?
Yeah, I don't have any experience of aspiration at the end or after the surgery, because I think lignocaine is very short acting, especially with the limits of body weight. We use quite dilute lignocaine, so most likely after surgery, even a brief one, the lignocaine will be gone. The effect of lignocaine will be gone. Yeah.
Nice. Yeah, I think we are
And
ready.
I think,
Dr.
I think one of the things to do is, ensure you do a good suction, clear the airway, and you actually turn the child to lateral position. All those things help as well with secretions at the end of the procedure. Yeah.
I think that's the best. Yeah, make sure that the airway and the surgical field is clean and there's no blood and secretion. Dr. Usha, would you like to introduce our last speaker for this afternoon?
Okay. So I think we've had a very interesting session, and we will top it off with our final panelist, and she is Mira Kurup, and she will speak to us on an infant needing intra-op monitoring for surgery. No gas, please. Please welcome Mira. Thank you.
Good morning, everyone. As part of the final segment of this track of total intravenous anesthesia, I'm happy to share with you a case of mine. For an infant coming for spinal surgery, there is neuromonitoring needed, and so no gas, please. I'm Dr. Mira Kurup, consultant pediatric anaesthetist at King's College Hospital, London in United Kingdom. King's is a tertiary referral center for pediatrics in the south of London. And on the right side, you can see the crowded view of our aerial view. King's is special for pediatrics in that we specialize in pediatric neurosurgery and pediatric liver, in addition to other subspecialties. So coming back to my case of pediatric patients needing total intravenous anesthesia. So this is a case for spinal surgery, spinal neurosurgery, and they need intraoperative monitoring. So the halogenated anesthetic gases will dampen the electrophysiological monitoring. So they requested specifically no use of inhalation agents. So hence the use of total intravenous anesthesia. So the case specifics now. This is an 8-month-old child, 8.6 kilo. and she's coming for laminectomy of L4-S1 and resection of a cutaneous appendage and untethering of the spinal cord, and in addition, a removal of lipoma, of an intradural lipoma. The pictures I have shown, my neurosurgical colleague, surgeon, says that it's not good enough, but I just wanted to show you the lipoma and the intradural extension. So, infant coming for spinal surgery, IONM, it's a complicated case. So the day starts with the planning, the briefing between the neurosurgeon, the anesthetic team, and the electrophysiologist. The surgical requirements is proning the patient. They state a surgical time of 7 hours, so about 9 to 10 hours. Intraoperative neuromonitoring throughout, and we were planning to use Medtronic NIM Eclipse E4, which is operated by the electrophysiologist, and antibiotics. The anesthetic plan is to titrate total intravenous anesthesia according to the BIS and spectral edge frequency as given by the electrophysiologist. So, as any pediatric anesthetists who are all there in the audience will know, planning a pediatric anesthesia is to show the control to the parents. No last minute running around. This is so very important with total intravenous anesthesia because we are operating different pumps and with the parents in situ when we're starting the anesthesia. So my plan was to use continuous total intravenous anesthesia with propofol as a pedifusor model, total intravenous anesthesia of remifentanil, Minto model in the microgram per kilogram per minute. So propofol is microgram per ml, that is TCI, Tiva for remifentanil, and IV dexmedetomidine, which I plan to incorporate since it's because of its propofol sparing effect. I plan to use phenylephrine as an infusion for hemodynamic stability, then intravenous lines after the induction, interventricular and radial artery for monitoring, and never forget the bite block. So this was my plan for induction. The child was coming in with pre-existing intravenous cannula, and hence my decision for intravenous induction. If otherwise, if my plan B was, if the cannula is not working or if there was no cannula, my plan B was inhalation induction and then move on to intravenous anesthesia. So the next 3 slides, I will flip in between just to elaborate on induction, which is the most important point. The child and the mother has come, and this is my induction syringes. So let's concentrate on remifentanil, the bottom syringe. So remifentanil I have set at 0.1 microgram per kilogram per minute because the child is resting on mom's arms and I'm connecting my infusion set. And as I dialed in the age and the weight of the child, the Minto model of Tiva remifentanil goes down to 1 year. I'm very much aware that the child is 8 months old. So I put it at 0.1 microgram per kilogram per minute. And I will start with remifentanil. And as I'm starting, I put the time of induction of the remifentanil longer so that there's no sudden apneas. It's almost sure that apnea will not happen at 0.1 mic, but still, to make it easy, I put the time of induction longer. So I increase the remain to 0.3 microgram per kilogram per minute. And by that time, the child is accepting oxygen mask. Then, after giving a lignocaine bolus to reduce the induction dose, pain for induction dose of propofol, I started propofol 1%. As you can see in the earlier slide, I started it at 2 microgram per ml, and then I rapidly increased it to 4 microgram per ml. And at that time, the child has lost consciousness and we send the mother away. So these two are going through our intravenous cannula. This is very important to know. So the infusion set that I've used for TCI for this infant is the same as that for an adult. So the infusion set, I'm going back to the slide again. So this infusion set has got 2 limbs for propofol and remi, and at the distal end, the infusion, the channels join together. So the propofol and Remi runs together. The set is heavy, so every effort should be made to keep the limb stable, mainly the job of the assistant, so that the infusion set or the cannula will not get disconnected. So my induction has happened now at 4.5 microgram per ml of propofol and 0.3 microgram per kilogram per minute of remifentanil. And I use the muscle, going back again, use the muscle relaxant for intubation and then continue with my total intravenous anesthesia. So I use entropy during this period. And this is very important because induction needs a higher dose of inducing agent. And if you continue with that, the child will go into deeper state of anesthesia while the electrophysiological monitoring is happening. The electrodes are being put in, which is about 20 to 30 minutes. So coming back again, so this is the induction dose. So this is my monitor at induction. You can see that the entropy rate remains at 50. So that is reasonable for induction. And once the electrophysiology has been established, you can see that the BIS, as counted from the spectral edge frequency, I'm again bringing my pointer. This is a screen with the spectral edge frequency, and BIS is on the top as three definite, summary of three definite waveforms, and BIS is around 40, which is again used, okay, which titrates with entropy. Intraoperatively, once that the child has been positioned in the prone position and the lines has been put in, I started dexmedetomidine at 0.2 mic per kilo per minute, per hour, 0.2 microgram per kilogram per hour. Why do I need dexmedetomidine? I'm mindful of the fact that this is a 7 to 8 hour surgery. So my aim was to do some propofol sparing because this is an infant. But I had to stop dexmedetomidine. As you all know, that it dampens the EEG waves, and it dampens more than that, it dampens the EMG waves. So motor evoked potentials were dampened, and I couldn't continue with that. So my propofol TCI dose throughout was between 4 to 4.5 microgram per ml plasma site concentration, and remifentanil was titrated down to 3.5 microgram per ml. I gave morphine 0.1 milligram per kilogram quite early for the sparing effect of propofol and remifentanil. BIS remained 40 during the long wait for the start of surgery, and the surgery usually starts around 1 hour into our anesthesia. And BIS remained 45 to 50 microgram during the procedure. BIS remained 45 to 50 during the procedure. So when you're using TCI and Tiva and total intravenous anesthesia in children, always be aware of the propofol infusion syndrome. So you have to monitor the end organs. So arterial blood gases, the lactate remained 0.8 and base deficit at minus 1.9, 1 hour into procedure. 7 hours into procedure, lactate 0.7 and base deficit minus 4.3. The procedures lasted for 8 hours, and the extubation. So when using TCI in infants, the articles which has been published say you dial it down or stop it during the skin closure, because this child is in prone position and all the electrophysiology electrodes has to be removed. I stopped my infusion only at the end of the skin closure and before making the child supine. The extubation happened 15 to 20 minutes after the procedure, and the child was fully awake. So this is a BIS at the time of hemostasis of the wound. So this is once again, I'm bringing my pointer in. This is a spectral edge frequency, and BIS remains again around 40. The child was sent to the high dependency unit overnight. Nurse control anesthesia was prescribed and started in the recovery unit, and she was moving all her limbs. So, a few pointers about using total intravenous anesthesia in neonates or infants for long cases. Always have a low threshold for central access, especially if the surgeon is planning to drape the whole body of the child. We need to make sure that as a functioning access is there, established throughout the procedure. And the rate of infusion has to be guided by the nurse monitor or the BIS, or as in my case, using the electrophysiology, using the BIS and the spectral edge frequency. This is a must. Otherwise, a heart rate and blood pressure and tidal CO2 will not give you an accurate depth of anesthesia. If the operating time is prolonged, always make sure that the end organs remain safe. Arterial blood gases, urine output, and lactate and base deficit has to be measured periodically. Thank you.
For a very interesting talk and very challenging way of doing the case. I would just like to bring up this poll that we had. And the question was, do you use neuromonitoring such as SedLine or BIS for infants coming for spine surgery under Tiva or TCI? So 49% said all the time, and 14% said sometimes when indicated, and 37% said never. I'm more comfortable titrating infusion using hemodynamic parameters. So what is your comment on that, Mira? There seems to be quite a big group that prefer just using hemodynamic monitoring.
Okay, that's a controversial subject. As you know, spinal surgery, so prone position, if you are definitely using muscle relaxant, my take is you need to use neuromonitoring, meaning neuromonitoring in the sense that not an elaborate neuromonitoring as we had to use for EMG with the EEG and SSEP, but for me, you should use BIS or entropy. Sorry.
Yeah.
There's no other take for me.
Yeah.
So I think we can ask our other speakers, because the question really here is, do you use neuromonitoring for all of your spine cases? And then, or if you're not using, do you have any certain patient criteria wherein you use neuromonitoring when you are using Tiva TCI, or do you use Tiva TCI? When you use Tiva TCI, you use neuromonitoring all the time. Yeah, I think I start with Dr. Vivian. So if you use Tiva TCI, right, even in your airway cases and all that, I think some already asked previously that during endoscopic airway assessment, do you use your neuromonitoring all the time? Or do you have certain patients that you will use, but certain patients that you will not? Yeah, Dr. Vivian?
Okay, so for the airway cases, most often they are small baby. The electrodes or the sensors are usually too big, right? But for ordinary, like general cases of Tiva, TCI, propofol, if I don't use muscle relaxant, I'm quite comfortably do the case without the monitor. And also because they are brief. So you don't really have that much time to put the monitor as well. Then before you know the surgery is done. But for long cases, and also for high-risk patient, including obese patient with mental disability like the cerebral palsy or metabolic disease and so on, I use neuromonitor as far as possible. I mean, the depth of anesthesia monitor as far as possible. So I try and use, just sometimes it's not feasible to use because the case is short, and I'm okay not to use because for a lot of cases, the brief case, I don't use muscle relaxant.
I see. How about Dr. Ina?
Okay. We have to look back the reason why we need to use this neuromonitoring. First is to ensure there's no awareness. Second is to also ensure that we are not overdosing the patient with drugs and causing hemodynamic instability. So for the first purpose, if I don't paralyze the patient, then I would not use neuromonitoring because it's quite expensive. In Malaysia, it's purely back to cost for us. And also previously, there's a lot of controversial of using EEG monitoring in children because all this data are previously taken from adult data. And you know, children's brain is an evolving process, so it doesn't reflect truly. However, this has been becoming more and more, there's more updates on this. So there's more data coming up for children's beats in children or EEG monitoring children. So I think when there are adequate evidence, probably that's the way to go. Secondly, the use, for my case, if you think there's a query that you would want, there's query that hemodynamic will be compromised, you know, then it's good to use neuromonitoring so that you don't overdose these children with unnecessary drug like propofol and remifentanil that can be hazardous to the end at the end of the day, because at the end it's the patient safety that is what we want to ensure.
Yeah,
That's
thank
my
you very much, Dr. Ina. I think you mentioned that there are, I mean, right now there are a lot of monitors. There are a lot of advancements in terms of neuromonitoring. Currently, we have SedLine, we have BIS, and other things. I think one of the questions here, right, I think Dr. Vivian mentioned also earlier on, for very small patients, neonates, less than 3 months, do you use neuromonitoring? Dr. Mira, first, yeah.
Say that question again. Very short cases or small children?
It could be short or long cases. I mean, let's say same thing. Neuro spine, like meningocele excision prone position. 3 months or 3 months old or 2 months old. Yeah.
Okay, so it depends on the surgeon. There are some surgeons who close the meningocele in 2 hours time. I'm happy without that neuromonitoring. But if the surgeon takes more than 4 hours, I need the neuromonitoring. We talk about it's not specific. It's not the what do you say? It's not 100% true for neonates and for infants, but when we use neuromonitoring for children like BIS or entropy or narcotrend, what we are doing is the trend. If the trend falls down, we need to reduce the anesthesia, isn't it? Even for sevoflurane or TCI or Tiva, we need to reduce it. So that's what we are looking for here. Or the nurse, we are looking for the trend of reducing values,
Yes.
meaning the deeper anesthesia.
Correct.
Yeah. If a shorter case, we don't need to. We can get away with just hemodynamic monitoring.
I see. Yeah, I actually agree, because with the neuromonitoring, you'll be brave enough to provide the minimum essential anesthetic to the child without actually worrying about patient moving during the surgery, or patient will, have some issues because of inadequate depth. Yeah. So I think if our audience wants to learn more about neuromonitoring in EEG, tomorrow we have a workshop for EEG and neuromonitoring by Dr. Bong Chun Lei, Mr. Perdue, and Dr. Melody. So please attend that workshop. So I will share now the question from Dr. Soichiro. So he also commented that I think, and I quote, I think sophisticated open TCI systems or pumps have not been available in several countries, which is true. Instead, we are able to use some app to model pharmacokinetics. So his questions are, do we need remifentanil TCI? Because remifentanil is very short acting with rapidly metabolized, or do we just use the regular microgram per kilogram per minute infusion that we have? Or do you have any recommendations of app for PK and PD for neonates and children? So he's discussing about remifentanil. I think I will ask Dr. Vivian, can you comment on this? If, let's say, if you don't have a sophisticated remifentanil Minto model, what do you suggest, or what is your recommendation?
I think if you have mental model and the kids is big enough, you can use TCI. But because pharmacokinetic of remifentanil is quite linear, so it's also quite easily used with just manual infusion. And yeah, especially if you don't need the kids to breathe, then it's even easier. So I don't. But to my knowledge, there is no model as yet for kids, for the younger population as yet.
Yeah. What's the youngest for remifentanil that you usually mean the recommendations that you'll provide for our viewers for remifentanil? Minto model, Dr. Vivian?
12 years and 30 kilo body weight. That's the current recommendation. Yeah.
So any younger than that, you will just use?
I just use manual. Yeah.
How about you, Mira?
Because manual infusion for Remy is so easy. So sometimes when we have big kid, I forgot about the TCI as well, because it's just quite easy to use without the TCI model in terms of remifentanil, with the very short context sensitive half time. Yeah.
I see. Dr. Mira, how about you?
The same. For this child, I use the microgram per kilogram per minute. I've used Remy neonates. Again, sometimes we have to take the theater to the neonatal intensive care unit because of the child being on oscillator or too sick to transfer. So we take Remy to them, and minute doses of propofol and Remy.
Okay, last question from Dr. Evangeline. Then what if, let's say, for example, right, this patient had propofol infusion syndrome from the previous GA, and then coming back now, and you're planning to are you going to consider carrying it on with TCI? So this patient went for a surgery before, had a propofol infusion syndrome, because maybe a long procedure. Will you and then coming back again for another GA, will you consider using TCI? Dr. Ina?
There's a few factors that I will probably take into consideration. First of all, I need to know what sort of surgery does the patient coming back to. Is it really indicated to use Tiva? And and then what was the reason for the priest the last time, because maybe the patient previously was septic or hypotensive for prolonged op. So we need to know that extra information. However, if everything is just an incident report, because otherwise patient is okay and just had priest, then if it's not indicated, I would not use.
Okay. Thank you very much. Yeah, I think we are come to the end of our track. We are 1 minute left. Thank you very much to our speakers, Dr. Vivian, Dr. Idna, and Dr. Mira. Thank you, Dr. Usha. Would you like to say something to our viewers? Dr. Usha? I think you're muted. Yeah, okay. Thank you very much, Dr. Usha. Yeah, we hope our sessions shared valuable techniques that you and our viewers, of course, our viewers can apply and face similar challenging pediatric cases. Thank you very much, everyone. Maraming salamat po.
Thank you, Teddy and Asha.